So again, thank you so much for your time and your patience, and I'm going to go ahead and start the presentation. Thank you.
Hello, I'm Dr. Randy Moore with MSK Masters, and today is going to be the last in a series of 4 videos that we're producing on PRP, platelet-rich plasma procedures. And today we're going to be focusing on nerve hydrodissection, specifically the median nerve in the wrist. We're going to hydrodissect that and then perform a percutaneous release of the flexor retinaculum to help this patient that is experiencing median nerve symptoms, carpal tunnel syndrome type of scenario. That being said, with this being the last in the series, I want to re-emphasize that a step-by-step protocol, a comprehensive and targeted treatment plan is necessary in all of this. Ultrasound guidance obviously is required. And lastly, to reiterate my mantra, your injection is no better than your image. And they're going to employ all of that today in this video. So let's go ahead and get started with this. Okay, so let's go through the case study for our patient that we did. We're going to do the hydrodissection of the median nerve and the percutaneous release of the flexor retinaculum and the transverse carpal ligament. Nerve hydrodissection, let me just start off with this. Nerve hydrodissection can be done basically anywhere in the body. We're focusing on the median nerve in the wrist, in the carpal tunnel today, but you can do nerve hydrodissection wherever you can identify a nerve with ultrasound, with the ulnar nerve in the elbow for a cubital tunnel, blocking nerves like you'll see in this procedure for blocking the nerves for patient comfort when you're working on the hand, blocking the nerves in the lower extremity when you're doing extensive work in the foot, hydrodissection of other nerves, dorsal scapular nerve for people that supposedly have trigger points. That nerve is routinely involved in people that complain of trigger points, and those situations are resolved much easier with hydrodissection of that nerve. So hydrodissection is a big component in a point-of-care ultrasound. Regenerative medicine, it's a crucial part of it because you're not just going to be injecting muscles, ligaments, and tendons and joints like we have in the previous videos. This is just a taste of what it's like to hydrodissect a nerve and do a percutaneous release that can yield enormous benefits to the patient. And it's not a hard procedure to learn. It's not a hard skill to learn. People just need to be shown. So let's go through this short case study and discuss our treatment plan. So our patient is a 53-year-old female. She has bilateral hand numbness and paresthesia. Mainly, she wakes up with it in the morning. She has minimal weakness. There's no motor weakness that is associated with this. Just a standard type of numbness and tingling and some weakness that goes along with carpal tunnel median nerve compression, and something that we can address quite easily. She's a former dental hygienist for 20 plus years, so a lot of intricate work with her hands for a lot of years, and different type of stresses and orientations that she would have to do there. She has no surgical history in this area relative to carpal tunnel release surgery, no systemic issues or health issues that would preclude us from treating her, no significant injuries to the wrist either. So this is your classic type of overuse type of syndrome that occurs for many, many people developing carpal tunnel syndrome. So the ultrasound findings of the median nerve, we employed what is commonly known as the wrist to forearm ratio. To my knowledge, it's going to be the most accurate and efficient way to establish the presence of true median nerve entrapment or enlargement. And so the first finding that we have here at the distal portion of the wrist to forearm ratio protocol, it's in my my wrist and hand lecture. We found a cross-sectional measurement of 10 millimeters squared. You can see here in the ultrasound image over here, we use the elliptical feature of the ultrasound system to do a cross-sectional measurement of the nerve here, measured 10 millimeters squared. If it had an irregular contour, then you would need to utilize the manual trace type of measurement tool to get a good accurate value of the cross-sectional area as the nerve is just about ready to enter into the carpal tunnel. Step number 2 in the wrist to forearm ratio, our measurement was found to be 5 millimeters squared. We found the median nerve at the level between the flexor digitorum superficialis and the flexor digitorum profundus. And so this is step 2 of the wrist to forearm ratio. The ratio calculation left us with a value of 2. Anything greater than a 1.4 is positive, almost 100% sensitive and specific for carpal tunnel syndrome. And so we use this quite frequently, and here is our cross-sectional measurement of the median nerve at the level between the FDS, which is labeled, and the FDP, which is also labeled. So there's the nerve, and there's the interface between the two muscles, and then we did our measurement at that level. So as part of this protocol, according to the patient's complaint, they asked us to look at it, and we looked at their thumb, which ended up being the problem in the first carpal metacarpal joint. And so we did that evaluation. We're going to treat it, we're going to include it in this treatment protocol. So the way that I find the first CMC is to be as specific as possible. And I count 3 joint spaces. I count between the radius and the scaphoid and the trapezium, and then trapezium to the metacarpal. And by counting those 3 joint spaces, I know then looking at the correct joint, it is easy to be incorrect about that. So here we have the dorsal component of the first CMC joint. There's trapezium, there's metacarpal, obvious joint effusion that we see in the joint, some debris and bony destruction that's been going on here for a while. Also, before I move on, I'd like to make mention that I am using an acoustic stand-up pad for the diagnostic portion of the image. Because the protocol, because I can't use this during the injections, but it does let me have a better probe contact around some of these superficial joints and gives me a better view of what's going on. So that's the dorsal side of the CMC. There's the effusion that we see on this image. The second part of my evaluation of the carpal metacarpal joint is I take the time to look at the palmar side of the joint. The reason being is that on the palmar side, I find a lot more joint effusions and bony degeneration than I do on the dorsal side. And in keeping with my mindset of specificity of placement cannot be overstated in these areas, it's good to look at both sides and inject both sides of this joint to get the optimal response from the procedure. So here we have, again, still using the acoustic stand-up pad. There's the irregular bony contour of the trapezium. Here's the metacarpal. Here's the joint space, and there's more debris that is floating and present here within the joint space. So it's an obvious target for us to complete our endeavor to provide comprehensive yet targeted treatment protocols in all of our regenerative medicine protocols. So the treatment plan after the diagnostic imaging is this. We're going to hydrodissect the right median nerve with the short axis probe placement. We're going to see how much volume it can handle. We're going to put in 1.5 to 2 milliliters of platelet-rich plasma. We're going to advance the needle above and below the nerve to float the nerve in the PRP to truly hydrodissect it, and also bathe the nerve in that regenerative product to help heal the nerve as well. So to decompress and heal is going to be the intent. The second injection was going to be a short axis percutaneous release of the flexor retinaculum and the transverse carpal ligament. Those two structures are interdigitated, they're blended, and difficult to see as being distinct from one another, but we're going to thread the needle through that combined interface and do a little bit of fenestration and release that area. And then we're going to inject the first carpal, metacarpal joint on the dorsal side, and we'll inject 0.5 to 0.75 mLs out of plane into that area. And then we're going to drop down onto the palmar side of the joint, and the same thing, inject about 0.5 to 0.75 mLs into that joint space, because that's about all it can handle. As part of this procedure, we're going to be blocking nerves to keep the patient comfortable. In addition to that, we block the nerves for another reason. That is, you don't want to deposit a bunch of anesthetic, lidocaine, right there at the area of the carpal tunnel, because the lidocaine is going to affect the cell activity of whatever it is you're injecting. So we chose to block the radial nerve and the median nerve, and it's not on the slide here, but I also, just to let you know, I did a ring block just proximal to the first CMC, just to make sure that everything was numbed up and keeping the patient comfortable. So the procedural sequence that we said through all of these videos is, number one, you get your diagnosis. You get your diagnosis using a good diagnostic ultrasound system and learning how to do standard imaging protocols. Secondly, from your diagnostic exam, you determine your treatment sites. Thirdly, at the treatment sites, you're going to determine the volumes that can be injected into those areas. And then lastly, you follow your treatment plan. And by doing those in sequence like that, that is what brings your regenerative medicine practice from a hit or miss type of a practice to one that gets consistent results for the patients. Thank you. So now we're going to do just a very simple, fairly brief hand and wrist exam. We're going to be focusing on the median nerve and the carpal tunnel evaluation, which is where our treatment plan is going to end up. But we're going to place the probe in a short axis orientation right here at the crease of the wrist, right here in the area of the flexor retinaculum. My reference marker on the transducer is going to be going in a radial direction. So on the left side of the image will be radial, and the right side of the image will be ulnar. And then we're going to go through a couple of dynamic maneuvers to help us identify the median nerve, because sometimes it's not something that just jumps off the screen for you. So we make sure we localize the median nerve accurately. So when we do, as far as the dynamic maneuvers that we're going to have the patient do, we're going to ask them to just flex their thumb back and forth to activate the flexor pollicis longus. That will help us identify the median nerve. And then at times I have the patient just roll their hand up into a light fist, and that will contract the flexor tendons, the flexor digitorum superficialis and profundus. Makes those tendons just a little bit more echogenic and prominent, which again helps us to identify where the median nerve is. Lastly, when we do show you the median nerve image, I think you're going to be quite surprised at how superficial the nerve is, which further indicates those physicians that are doing blind, non-guided injection into the carpal tunnel. It's extremely easy to just go too deep and actually miss where the nerve is to get the best benefit. So we're going to take the transducer, place it in short axis right at the crease, and there we have a nice image. Let me just turn my gain up just slightly. There we go. And again, left side is radial, right side is ulnar. And then if we ask the patient just to slowly flex their thumb back and forth, just do that repeatedly for us. There you can see the movement of the flexor pollicis longus tendon as he continues to do that for us. And as you look at that tendon, you go up or superficial, and to the right of the image, you can see the oblong ovoid presentation of the median nerve. You can see the upper portion, the lower portion of the epineurium, a bright hyperechoic ring of the epineurium, and that is our median nerve that is just proximal to the entry into the true carpal tunnel. So I'm going to freeze the image and use my arrow to point out. This was the area of the flexor pollicis longus that we saw being activated as a patient flexed their thumb back and forth. We go up and to the ulnar side of the image, and that always takes us every time to the median nerve. So that's one way to help localize the median nerve. It's a very efficient way to do it. Another way to make it a bit even more prominent is to come back and find the median nerve. Again, the arrow is still at the median nerve, but then ask the patient to roll their hands up into a light fist. And there you see the bright hyperechoic, circular, almost ovate presentations of the 2 rows of the flexor tendons that go down into the fingers to help you localize the difference in the echo texture between a hyperechoic bristle-like pattern of the tendon and the darker hypoechoic presentation of the median nerve. So that's median nerve imaging as far as localizing it here. At the entrance of the carpal tunnel, we can go a little bit more distal and try to keep the median nerve centered on the image. As we go medial, we get down into the true entry into the carpal tunnel, which is right here. Don't want to lose the nerve. And so right here at the entry into the carpal tunnel, we see some of the carpal bones, and we should go, if we go a little bit farther on the far left, we'll pick up over here. This is going to be, this is scaphoid here, and then we come towards the ulnar side. This is pisiform here. There's the ulnar artery that's pulsing here. So this is the true entry into the carpal tunnel. We'll come back. We're going to localize our median nerve again. Here it is right in the dead center of the image. Again, it's important to keep in mind that when you're looking for peripheral nerves in cross-section or short axis like this, look for the bright hyperechoic epineurium of the nerve first instead of the internal architecture of the nerve, and that's going to help you find these peripheral nerves much better. So this is our initial image on the patient. I'm going to cover the measurements that we did previously on this patient to show you that she does have carpal tunnel positive findings relative to what we're using the wrist to forearm ratio, where we measure the cross-sectional area of the nerve at the entry into the carpal tunnel, and we go approximately 12 centimeters this way to measure the nerve again, and then we do a simple ratio measurement to get our determination if she truly has carpal tunnel. So to image the nerve proximally, it's always good to put down a layer of gel. As you know, you're going to be translating the nerve from one point to the next. So we'll come back and we'll just kind of spread that gel back and forth to make sure we can do that easily. Unfreeze the image and move the arrow down here. So we're going to come back, we're going to find the median nerve, we're going to put it right in the middle of the image. Ask the patient just one more time to flex the thumb a couple of times so we can see the flexor pollicis longus activating. So there's our median nerve right there. Now we're going to take, we're going to do a translation maneuver. We're going to slide the transducer proximally up towards the elbow, and you can see the median nerve begin to take a leftward movement and then diving down deeper in between some muscles. And right now you don't really see it very well, but what you need to do is just keep sliding the transducer proximally, and then what happens is the median nerve slides in between the 2 layers of the flexor digitorum profundus and superficialis. If you have the patient make a tight fist, you can see those muscles contract. Go ahead and release your fist. Now contract again. Here you go. And just squeeze your fist. And then here is the median nerve. There we go. There's the median nerve over here, and the interface between the 2 muscles. Get this arrow straight. So here's the nerve in between the 2 muscles right here at the more proximal level, and this is where I would do the second measurement for the wrist to forearm ratio, and we'll cover that later in the video where we've done our imaging and measurements previously. So that's the diagnostic exam that we need to do today to evaluate for this patient to establish her need for the treatment we're going to do for the carpal tunnel release, the percutaneous release, and also the measurements to help confirm the need for the treatment. So now we need to evaluate the first carpal metacarpal joint on this patient, because she does report a lot of quite significant pain in the thumb region, which oftentimes is going to be involving the first carpal metacarpal joint. It's important to have the patient's thumb stabilized in some shape or fashion. In this case, I'm using a squeezy star to help stabilize her hand. And then I'm going to scan from proximal to distal on the image. Left side is proximal, right side is distal. And the way you can use ultrasound to clearly identify the first carpal metacarpal joint is to first identify the long hyperechoic reflection of the radius. And the radius extends off to the right and then curves down a little deeper in the image, and then you keep going to the right, and that bone reflection there, that's scaphoid. And as we continue following the axis of the thumb, then it's going to bring us to this trapezium, and then finally on the far right of the image is the first carpal metacarpal joint, and once you get there, then you can extend and flex the thumb and see the joint space open and close as you activate the joint. And so that's how you can identify where the first carpal metacarpal joint is. You can see the nearly anechoic fluid effusion that's distending the joint space. You can see the debris, synovium or perhaps osteoarthritic changes and cartilage fragments that might be floating around in the joint space. This is the dorsal side of the first carpal metacarpal joint, which is what everybody looks at. But again, in keeping with our mindset of comprehensive yet targeted, to be more comprehensive in this, to go from the dorsal component of the CMC joint and wrap your transducer around onto the palmar side of the joint. And if you redirect the transducer once you get over there, you can see even more effusion of the joint and more osteoarthritic conditions that are present here. So to do the best job on this patient, it's always going to be best to inject the dorsal component of the CMC and the palmar side of the CMC. Okay, so now we're going to do the first of the two-step process in this carpal tunnel region. We're going to hydrodissect the median nerve, which is that hypoechoic oblong structure on the right side of the image. You can see here we have a fairly large amount of sterile ultrasound gel that we're using as an acoustic standoff pad, which is really beneficial because we can see our needle prior to puncture, and the needle is going to advance from the ulnar side right to left on the ultrasound image and down towards the nerve. So we're going to advance the needle through the sterile gel slowly, then we should be able to see it. There it is before we puncture. We can see our needle angle is not correct, so we're going to correct it just a little bit. And now you can see we're pushing the skin and checking with the patient. Is this sharp?
No.
Okay, so we have a good block. We're going to puncture the skin. We're right under the median nerve. Doesn't take much to get there at all. That's why you can see it's very easy. So now we're injecting underneath the median nerve. It's very easy to go too deep. We're actually kind of floating the nerve upward as we inject the PRP here. And now we're going to retract the needle slowly, not going to come all the way out. And we're going to redirect and go up above the nerve. Make sure you find the needle tip and advance at a steeper angle, go up above the nerve, don't go through. Right there you get a glimpse of the 3 hyperechoic facets at the end of the needle tip. So I'm going to tip the needle a little more shallow, so I'm going to go right on top of the median nerve, glide it across the top. Make sure you maintain your probe contact so you can see as you inject. And now we're going to inject down onto the top of the median nerve, and we have bathed the median nerve in just about 2 cc's of platelet-rich plasma. So that's the hydrodissection of the median nerve under ultrasound guidance with excellent targeted placement here. Push in just a little bit more, because the thing to remember about doing these nerve hydrodissections is you decompress the nerve, but also the growth factors or the biocellular product that you're injecting can actually penetrate the epineurium and help to heal the nerve. So now we're going to We've done our hydrodissection. We're going to localize the needle from one end to the other, and we're going to slowly retract and come back out. The second part of the procedure, after we've hydrodissected the median nerve, and since we've changed our probe angle, now you can see the median nerve dead center on the image is kind of floating in the platelet-rich plasma that we just injected. Superficial to that is the combined interface of the flexor retinaculum and the transverse carpal ligament. So we're going to do a percutaneous release. I would ask the patient to flex her thumb back and forth, but she can't because of the nerve blocks. So we're going to advance the needle under visualization. We're going to come from right to left, and we're going to be extremely superficial. Again, asking the patient, do you feel this? Is it sharp? Okay, so here we go. We're going to puncture. We're going to bring the transducer a little closer to my needle so I find it before I advance any farther. I got to find that needle before we go anywhere. There's my needle. I do have about a 20-degree bend in the needle, and I advance the needle across, straight across, staying in the very superficial area of the retinaculum and the TCL, the transverse carpal ligament. I watch my needle tip go all the way across to the radial side. Again, I'm kind of flexing the needle and I'm advancing it all the way across, keeping that needle tip very visible. And once I get to the radial side, now's the time to inject. So as we retract the needle, we're going to inject the PRP, and there you can watch it separating the TCL and the flexor retinaculum and doing this percutaneous release that should give her a lot of relief relative to her carpal tunnel symptoms. So you can still see the needle tip. We're injecting as we retract, moving the needle or the probe with it so we can keep the needle on there very clearly and injecting into the retinaculum and the TCL.
All right, this was very great presentation. Thank you so much, Dr. Moore. Dr. Moore has prepared a quiz for you. So we're gonna launch the quiz, and you're gonna receive the results back in a week of the correct answers alongside with the recording. So something you answered was not correct, we can rewatch the recording. And you can also submit your questions to the Q&A box, and we'll forward it to Dr. Moore, and he will reach out with the responses. So I'm gonna share the quiz right now. And you should see it on your screens. There are 3 questions. Feel free to respond to those. And feel free to submit your questions into the Q&A box. Again, thank you so much for your patience with our earlier technical support issues. So we're grateful that you're here with us, and we hope you join us for the next webinar next month. It will be on the MSK topic as well, so hopefully you'll register and we'll be able to attend. If not, we'll also share the recording and post it on our website. But feel free to answer those quizzes. Thank you for the questions that you're submitting. Okay, I'm gonna give you another minute to respond. And then we have one more full question for you to see if you learned anything, if this was helpful, because the feedback you leave for us helps us to plan future webinars. So please feel free to answer the next question in a couple of seconds. Before you leave, if you can answer the next quiz or learning question that we have for you listed And again, this was recorded, so we will be sharing the recording shortly. In about a week, you will receive an email with the recording link as well as the presentation quiz answers. So thank you so much again for joining us today, and thank you again for your patience. Have a wonderful day.